So welcome everyone tonight to our online talk all about sleep, entitled What's the Best Approach to the Patient with Trouble Sleeping? And so my name's Barton Jennings. I'm going to start off the talk, and I'm joined also by Cheung, who's going to talk with me. So the first question is why we're doing this, and our sort of mission really is to help and inspire as many people as possible to improve their overall health while we take specialist attention to the treatment of lung and sleep disorders. And this is important because I believe that there are really 4 pillars of health, being exercise, sleep, healthy nutrition, and mental health. But I don't think you can really achieve optimal health without addressing all of these 4 areas, and they really interplay a lot with each other. And as we'll see tonight, certainly sleep and mental health have a strong interrelation, but so does exercise and nutrition. For a long time, people have sort of felt that maybe sleep is a sign of weakness. Everyone would have heard the saying, you can sleep when you're dead. People say, writing that email at 2 o'clock in the morning shows that they're really working hard. And it's sort of a badge of honor that somebody can sacrifice sleep to get more done. However, the problem is that a lack of sleep increases mortality. And we know this partly because of a global experiment that's performed in 70 countries around the world twice a year on 1.6 billion people. And that's daylight saving. And people have researched into the epidemiology of what goes on around daylight saving. And we consistently find that in springtime, when we lose an hour of sleep because the clocks go forwards, there's a 24% increase in heart attack, where the reverse happens in autumn. When we gain an extra hour of sleep, there's a 20% reduction in heart attack. And the same is seen with road accidents, poor mood, and suicide. Sleep has a strong effect on our immune system, and that has implication with regards to disease. And we know that a lack of sleep or sleep deprivation increases the risk of breast, bowel, and prostate cancer. It also increases the risk of Alzheimer's disease. So sleep is not a luxury. Sleep is a biological necessity. So if that's the case, what is normal sleep? What should we be trying to achieve? And so we can talk about the duration of sleep being important, how much sleep you get each night, and also the quality of sleep. So you might get adequate amount of sleep, but the quality might not be so good. And we talk about the proportion of non-REM to REM sleep without waking up or without arousal. We should have a short sleep latency. So when we go to bed with the view to sleep, we should be able to fall asleep within 20 minutes. We should be able to maintain sleep throughout the night without waking up. Our breathing should remain stable. And when we wake up, we should feel refreshed and alert. And we should not get sleepy during the day. And so if we achieve those things, we can say that we have good quality normal sleep. So the question is, how do we approach that patient who says, I can't sleep? And I'm sure that everybody's had the experience where you've seen a patient, you're just about to wrap everything up, and they say, and I can't sleep. And you think, oh my God, how am I going to approach that within the next 1 minute, or as I'm trying to finish up the consultation with this patient? And it can take a long time to sort out. And so what I wanted to try and do is put a bit of a system in place, which I use, and Tim and I have discussed a lot about how we approach a patient with sleep, not in that 1 minute, but at least when someone comes and says, I have difficulty sleeping, it can be really complicated to get through. And so the way we think about it is the first step is to optimize the quality of sleep, because it doesn't matter how long you sleep for, or if the quality of sleep is not good, then the patient is not going to get value from that sleep, and is going to feel sleepy during the day and not going to get all the benefits that you get from good sleep. We do that, as I'll talk about in a moment, through doing sleep studies. But if a patient's had a sleep study and there's no underlying sleep disorder, we know that the quality of sleep is adequate. The next thing is to make sure that the body clock is aligned. And this is an important second step and often missed, because as Tim will explain, if the body clock is not aligned, then it causes people to have a lot of difficulty with their sleep. The next thing is to make sure that mental health is optimized. And this has to be done third, because we have to do this, we have to make sure sleep quality is adequate, because if sleep quality is not adequate, that can have a significant effect on mental health. So we want to, it's hard to address mental health without making sure sleep quality is good and circadian rhythm is aligned. So we then look at the mental health, and if there are mental health issues, then they need to be explored and managed. And then once those three things are done, it's all about cultivating good sleeping habits. And so I'll say to patients that what we'll do is we'll make sure your sleep quality is good. Then we have to make sure that your body clock is aligned, make sure there's no mental health issues. And then if all those things are sorted out, then what we do is we concentrate on improving your sleep habits. And so what we're going to do now is step through those four things in a little bit more detail. So firstly, with sleep quality is the first consideration. And the way we do this is to do a sleep study. And when we look at the sleep study and we get the raw data from the sleep study, this is essentially what we look at. Across the top is a 30-second pain. Across the bottom one is 5 minutes. And we go through the whole night looking at all of that data. And so here we have the ECG to make sure there's no arrhythmia. Here's the EMG, which is the muscular tone. So we can tell if muscle tone is increased or decreased, and also if people have bruxism where they clench their jaw. This is all the EEG, which so we can tell whether someone is awake, whether they're asleep, whether they're arousing from sleep, and also what stage of sleep they're in. We look at their oximetry. This is airflow, and on this one it shows nice airflow with the patient breathing in and out with no reduction in airflow. And we also look at movements of chest and abdomen. We can tell if patients are snoring. We can tell what position that they're sleeping in, which is significant with regards to sleep apnea, because often it's worse when people are in the supine position because tongue and jaw fall backwards. And we also look at limb movements to see if people are kicking their legs around while they sleep, because if they do, that can cause sleep interruption and poor quality sleep. So here's another example of a patient with significant obstructive sleep apnea. And so here's the airflow, and you can see it starts off okay, but then it's marked in aqua there where there's a hypopnea, there's a reduction in airflow, and then that's followed by the patient briefly waking up and taking some extra deep breaths to bring their oxygen saturation up. And soon after there's that hypopnea, you can see that the oxygen desaturates by about 3 or 4%. Once the patient falls back to sleep, the cycle happens again, and they're having another apnea this time where there's complete cessation of breathing followed by high breathing up to resaturate. We can see that there's some snoring associated with that. And this is the summary page, and this is the page that you're probably more used to seeing across a timeline from 9 o'clock through to about 6 in the morning. This is the hypnograph that shows what stage of sleep the patient is in. And so if there's no color, they're awake. If there's yellow, that's light sleep, just as they're drifting off to sleep. So we should only really see a small amount of yellow sleep. Makes up about 5% of total sleep time. The green is non-REM sleep, good quality non-REM sleep. The blue down the bottom, which looks similar to the green, is deep sleep or slow wave sleep. And the bars at the top, which are in sort of a red color, that's REM sleep. This is arousal. So there's a few times throughout the night where the patient's woken up, but not too many. Looking at the position that they're sleeping in. This is the oxygen saturation. That's a pretty normal line across at about 100 or just less than 100%. And you can see along this line is when the breathing has slowed down for a hypopnea. And there's a couple of times throughout the night, but not many. And this is the summary sheet that we get. And that number down the bottom is the total AHI, or the number of times the breathing slows down or stops. And it's 1.7, which is normal. So less than 5 is normal. So this person, we can say, has good quality sleep because the sleep architecture is normal. There's no obstructive sleep apnea or periodic limb movements interfering with the quality of sleep. This, on the other hand, is someone with very severe obstructive sleep apnea. In the hypnogram, the first thing we see is that there's too much yellow. So the yellow is light sleep. This means that they're waking up frequently throughout the night, going into that yellow sleep just as they're drifting off again. But as soon as they're falling asleep, they're waking up again. Arousals are continuous throughout the night. Oxygen desaturation is up and down, up and down, up and down to very low levels throughout the whole night. And these are obstructive apneas, which are just consistently occurring non-stop throughout the night. And so this is a case of very severe obstructive sleep apnea with a total AHI of 90 something. So that's how we look at sleep quality. Certainly if patients are snoring or if they have daytime sleepiness, then that's the main things that make us think that there could be obstructive sleep apnea. But there's also other sleep disorders that we can pick up on sleep studies, such as restless leg syndrome is often associated with periodic limb movements of sleep, bruxism, which is grinding of the teeth. Sometimes patients just have pain. We won't pick that up on the sleep study, but there might be something else externally causing arousal from sleep and poor quality sleep. Sometimes it's the getting up to go to the toilet at nighttime, but often actually nocturia is due to sleep apnea. So if someone has nocturia, you always have to think, if they snore and they're getting sleepy, it might be that they have sleep apnea and that's causing the nocturia. And often treatment of sleep apnea results in fixing the nocturia, and patients are very grateful for that. They may have other medical illnesses or medications that contribute to their quality of sleep. So at Langer Sleep, we do a lot of sleep studies. We do sleep studies both in the hospital, and we utilise Cabrini, Southeastern Private, Epworth, and also Maryvale in Gippsland. And we also do home-based studies through our own service called Sleep Life Balance. We've got a referral form there that you can download if you'd like to use that for sleep studies. And here's me being wired up for my sleep study. With regards to sleep studies, we need to be aware that not all sleep studies are equal. And so sometimes people do cheap home-based sleep studies that might only monitor like a couple of different channels and a couple of different leads, really just to diagnose obstructive sleep apnea. And so the main role for home-based sleep studies is to confirm obstructive sleep apnea. However, if the sleep study is done well, and the home studies that we do monitor absolutely everything that we monitor at a hospital study, except videotaping the patient. And so they're significantly higher quality. So we need to be a bit wary of the home-based sleep studies that are often done by people trying to sell CPAP machines. Hospital studies are the gold standard, and especially if patients you think might have, it's not obstructive sleep apnea that you're looking for, or you want to exclude sleep apnea rather than prove it. And the next question is, of course, whether a sleep physician needs to be involved. And they don't have to always be involved. And I'm sure people will be familiar with the Medicare changes that have occurred. So in general practice, if you'd like to request a sleep study, you can do that if someone is thought to be at risk and symptomatic of sleep apnea. And so we just need to fulfill the criteria based on the Epworth sleepiness score, which is a score of how sleepy someone is, and they need to score at least 8. And they need to score 4 on the OSA 50, which tells us about risk for sleep apnea. So if the patient is at risk and is sleepy, then from general practice, you can book a sleep study. And we've got a referral form there that you can use if you'd like to use our service for sleep studies. And we can also organise home-based or hospital-based sleep studies for you. And if the patient qualifies, then we don't necessarily need to see them beforehand. If you'd like us to see them afterwards to discuss the results or to plan treatment, then we're very happy to. But otherwise, if you're comfortable in organising treatment, then you can just put on that referral that you'll follow up the result. And we're certainly very happy for you to do that. Of course, if the patient doesn't qualify based on those scoring systems for a sleep study, then Medicare stipulate that they do have to see a sleep physician first. So we're certainly happy to see them. We can organise a sleep study and plan from there. The stop bang criteria is similar, which I just find a little bit more complicated. So we tend to use the ESS and the OSA 50. If people have questions about that, I'm very happy to come back to it at the end, because it is a little bit complicated sometimes about the logistics of organising sleep studies. All right, on that note, I'm going to move on and introduce Tim Cheung once again and invite Tim to talk about disorders of body clock and also mental health issues that relate to sleep. That looks great. Excellent. Thanks, Tim.
Thank you, Barton. And thank you, everyone, for logging in tonight. My name's Tim Cheung, and I'll be speaking about the circadian rhythm and mental health and sleep. But firstly, I'd just like to pose a more fundamental question. Why do we sleep? And do we need sleep? We know that animals require sleep, and they also dream as well, because we can do those sleep studies that Barton showed you with all the channels, and we can record them having REM sleep, which implies they have a dream state. Some animals are capable of unihemispheric sleep, meaning that half the brain literally can sleep and half are awake. Happy to hand out any kudos to anyone who could name an example of one such animal. And if you answered dolphin, you'd be correct. Other acceptable answers would include fur seals and sea lions. All these animals are, of course, mammals, and they require surfacing to breathe. So the thought is that they've evolved that way to prevent drowning whilst they fall asleep. So dolphins literally sleep with one eye open. Of course, humans don't have that problem. So why do we need sleep? I guess another way to approach that question is, well, what happens when we don't sleep? You probably know from your own experience that if you stay awake, you feel groggy, feel tired, and you're not functioning as well. You might have heard had it said that sleep deprivation can impair your cognition to the point the same amount as being intoxicated with alcohol. And I think that quote actually stems from this particular study back in 2000, when a group of researchers from the University of New South Wales and Otago took 39 healthy volunteers, did a few cognitive and memory tests at baseline, then asked half the group to stay awake for 28 hours, and then gave half the group their favorite spirits to achieve a blood alcohol concentration of 0.1%, gave them a night to rest, and then swapped over. What they actually found that after about 17, 18 hours of sleep, the performance on their tests was equivalent of having a blood alcohol concentration of 0.05%, so the legal limit for driving. And when you looked at their performance at 24 hours, it was of without sleep, the blood alcohol concentration equivalent was 0.1%. So why do we sleep? It's a very complex process. And we know from different biological studies that there's different activities going on. There's clearance of toxins such as beta amyloid, implicated in development of Alzheimer's disease from the brain and tissues. There's the creation of hormones such as growth hormones, important for tissue growth and repair. And especially in children, neural development. REM sleep is very important for consolidation of memories. And from animals, again, we know that from an evolutionary perspective, that can conserve energy and reduce activity at night and the risk of being hunted by predators. How much sleep do we need? It's a complex question, but it varies from according to age. So the average adult, probably about 7 to 9 hours. And of course, that reduces as we age, but there's quite a wide range there. I'd like to now introduce you to the concept of biological rhythms. And we do observe these in life forms all the way from single cell organisms to complex humans and mammals. The circadian rhythm, which occurs about once a year, is seen in animals that hibernate or migrate from continent to continent, such as birds. Infradian rhythms happen less frequently than once a day, so maybe on a monthly or 28-day cycle, approximately. For example, the menstrual cycle. Circadian rhythms, which will be the main focus, happens roughly about once a day. They're governed biological processes such as hormone release and the sleep-wake cycle, governed by circadian rhythms. Then there's the ultradian rhythms, which happen more frequently than once a day. For example, the non-REM sleep cycles, you might see them on the sleep reports. They typically happen over 90 minutes. So here is the human circadian rhythm illustrated on a 24-hour diagram. And you can see the main points along that cycle, which are of interest, is different points along the cycle where there's release of certain hormones at the nadir and peak, for example, testosterone and melatonin. And that sort of governs our peak level of performance and vigilance, and also sleep as well. The lowest or nadir body temperature is actually a very important point along this cycle, which I'll go into, but just wanted to point out here. It occurs roughly around about 4:30 a.m. or 5 a.m. So the circadian rhythm, it's our internal body clock that modulates many different body functions, and it actually continues to tick on in complete isolation from light. So very early on, researchers from the 1960s locked themselves in a bunker, again with a few other healthy volunteers, and recorded their body temperature, their sleep and wake times, and as well as other things such as urine output. And they found that independent from light exposure, they kept cycling the body temperature, the sleep-wake cycle, And what they found it ran slightly longer than 24 hours. So the light and dark is not required for the circadian phase to keep, or circadian rhythm to keep operating, but the light and dark can help to shift or lock in your circadian phase. That's important for adjustment of it. The bright light is the strongest stimulus in regulating the circadian rhythm. It turns off the melatonin secretion. Timing is very important in shifting the circadian phase. And that point I alluded to before, the nadir body temperature is the key. If you're exposed to bright light before that time, it helps to delay the circadian phase. Whereas if you're exposed to bright light afterwards, it helps to advance or bring forward the sleep phase. The circadian rhythm isn't the only thing that controls our urge to sleep. There's also the concept of sleep pressure, and you might have heard of that termed as sleep debts as well. So sleep pressure builds the longer that we stay awake, and if we go to sleep, it takes away from that sleep pressure. So the optimal time to fall asleep is when you've built up enough sleep pressure to the maximum, and also it's the minimum of circadian alertness, generally when you have that burst of melatonin secretion around about 9 o'clock, which is illustrated where those arrows can almost converge. Of course, if you were to take a nap earlier in the day, say about 3 o'clock, then you take away from that sleep pressure. And that this diagram would be drastically different and make it more difficult to sleep at the usual preferred time in the late evenings. So just as every sort of biologic process, there can be dysregulation or dysfunction. And in terms of circadian rhythm problems, it's usually a shifting out of phase from what an acceptable sleep-wake cycle is. You can have delay in your sleep-wake phase or advanced sleep-wake phase, just shifting forward and back in that 24-hour cycle. Or you can have complete breakdown of the circadian rhythm in a regular sleep-wake phase disorder, where there's very erratic and almost random sort of sleep patterns. Non-24-hour sleep-wake rhythm disorders is often seen in people with vision impairment and in total blindness, where the circadian rhythm, because it's not quite 24 hours aligned, will gradually shift forward and forward and forward because of that loss of light stimulus to lock it and entrain it into a normal sleep-wake pattern. Shift work sleep disorder, jet lag disorder, they also very common and more sort of self-explanatory. So this is the changes in the circadian phase as a more illustrated, the black line being a normal sort of sleep phase, the blue dotted line when you have a delayed sleep phase, and the green is the opposite. How can we actually tell which phase that we're in, whether it's sort of where we are in it or whether it's aligned or not? Well, the most low-tech way is with a sleep diary. Just asking our patients to record down each morning when they wake up, what approximate time they think they went to bed, what time they woke up, and how much time they spent awake, activities before. Actigraphy is basically a fancier Fitbit, a watch or similar sort of device that records your body activity. So when we're sort of rested at night, low activity, it records that as sleep, and more sophisticated devices can actually tell what types of light and light frequencies you have been exposed to at certain times as well. Even more sophisticated than that is dim light melatonin onset testing, where we can actually test the level of salivary melatonin to determine the peak, and from that we can infer where the circadian phase is. I'd like to just elaborate more on sleep-wake phase disorder, delayed sleep-wake phase disorder, given that it's so common. The problem here is a delay in the sleep phase relative to where your desired or required sleep time and wake up time is. The body clock has been delayed relative to normal, and it's more common in people with a nocturnal chronotype, or night owls. The ways that we can help to fix this, we've got two choices. You can adjust your life to suit your sleep, or adjust your sleep to suit your life. To adjust your sleep, there's different options. So there's chronotherapy, where you adjust your sleep pattern and wake up pattern, starting by just setting your alarm at your most natural wake up time, and then gradually bringing that earlier every few days. Now, that usually isn't adequate in isolation. It has to be something else. Bright light being the most important stimulus in locking in the circadian rhythm. It's been found that on first waking, 40 minutes of bright light exposure helps to lock in the circadian phase. And in certain climates and it's difficult sometimes, depending on season as well, to have that. So light therapy goggles have been developed where people can wear these goggles, and it emits the right frequency of light to best give that stimulus. Timed melatonin can also help. Typically, we start with very low doses, even 0.5 to 1 milligram is enough to help shift the circadian phase. Higher doses may have more of a hypnotic effect, but don't necessarily help any more in changing the circadian phase. Sedatives, benzodiazepines, etc., do help with that hypnotic effect, but do not affect the shifting the circadian phase. So that's very important to know. Shift workers as a special population. 16% of Australian workers are shift workers. People in healthcare and mining especially tend to have day and night shifts. They tend to get less sleep than non-shift workers. And a certain proportion of those, 10 to 15%, may experience shift work sleep disorder. That's defined as having insomnia and or excessive sleepiness accompanied by reduced sleep. And there's certain risk in that is impaired decision-making, reduced reaction time, of course, higher risk of road accidents, especially after their night shift. So optimizing sleep, what's the best way? First is to tell the patients to listen to their body. Go to sleep when you feel naturally sleepy. And one key question to ask is if they feel sleepy on their couch in the lounge, but when they go back into their bedroom, they're completely wide awake and they don't feel sleepy at all. Well, that tells me that it's probably not a circadian phase problem. It's probably more of an acute insomnia sort of issue. Very important not to spend too much time in bed. That can be counterproductive. And also stimulus control, meaning that the bedroom should ideally be used just for sleep. Intermittent activities are all right, but you don't want to make that psychological association between the bedroom and stress. That can be most detrimental to encouraging sleep. Sleep phase can be shifted, but it really requires commitment from the patient and have to be disciplined in maintaining an unfamiliar initially and a changing sleep pattern, which you have to change every few days. So that can be sometimes difficult to maintain and need a bit of encouragement. And also that they may start to feel worse before getting better as they adjust to this new sleeping pattern. So not great to start at a time where there might be safety critical work, for example, an important project coming up. I'll shift on to talking about sleep and mental health. We know that the deficiency in sleep or poor sleep quality has lots of impact on performance and physical conditions, but also we can't ignore the effect it has on mental health as well. By large, the greatest problem with sleep and mental health is not getting enough sleep. About 4 in 5 long-term poor sleepers suffer from low mood and are 7 times more likely to feel helpless as well. It's a vicious cycle. Stress leads to poor sleep, leads to anxiety, and it goes around in a cycle like that. Poor sleep quality has been linked with greater relationship stress, and the relationship between the mental health and poor sleep is very severe. So sleep disorders can have an impact on mental health. You know that obstructive sleep apnea is associated with reduced performance, decision-making, and memory. Treatment with CPAP therapy for people's sleep apnea actually improves their vigilance and depression in the randomized controlled trials. In some studies, actually more than reducing their cardiovascular outcomes. Insomnia also occurs in many mental health conditions, and a mainstay of treatment of chronic insomnia is cognitive behavioral therapy. Many of the same strategies used in depression, for example. Narcolepsy, a neurological central disorder of hypersomnolence, is associated with high risk of mental health conditions such as depression as well. And then there's also the inverse. So symptoms of poor sleep as part of a mental health condition. Now, highlighting a few here on the screen. In depression, we know that sleep disorders disrupt serotonin function. So if you have a comorbid sleep disorder, it can make depression more difficult to treat. People with obsessive compulsive disorder tend to have a shorter sleep duration that puts them at high risk of circadian rhythm disorder. Seasonal affective disorder, excessive sleepiness is a key symptom of that, and also treated with light therapy, which can affect their circadian phase. Patients with PTSD often find that they have sleep disturbance, and of course, flashbacks and very debilitating, vivid nightmares are a feature of that condition, which can be treatable with certain medications. You may have heard prazosin is used off-label for treatment of that. So I'd just like to end up with, often get asked about dreams and their meanings by some of the patients. I know that our psychiatry colleagues, of course, place a lot of emphasis, and especially if they are prescribed to the school of psychoanalytic theories like Freud and Jung. But to a sleep physician, it's all REM to us. So with that, I'll hand it back to you, Barton.
Excellent. Thank you, Tim. I find the circadian rhythm disorders so interesting, and I think, as I said, sometimes, often, probably under-recognized. As I said, once we have the sleep quality optimized, we're sleeping at the time that our body clock wants us to be asleep, and we've addressed mental health issues, then if patients still have problems with their sleep, then it's all about sleep hygiene and developing good sleeping habits and avoiding bad sleeping habits. And so I think of 6 good sleeping habits, and Tim's spoken about maintaining a regular sleep pattern. So the more regular the time that you go to bed and the time that you wake up, the better. The more variability, the less likely your sleep will be of good quality, and it can cause difficulty in getting to sleep and waking up more frequently throughout the night. We need to have a regular bedtime routine, so time to wind down. So it's not a good idea to be on the computer working away and then right up until the time you go to bed. If I try and go to bed straight after finishing this talk, I'm probably not going to be able to go to sleep. So I'll have a period of wind down before going to sleep. Sometimes people have a list of things on their mind that always tends to pop into their head at nighttime. And so people wake up at nighttime and then suddenly go through all of the things that they need to do the next day. And so people often find it useful to write down a list or just get it out of your head. So if you write it down, push it aside, say, okay, I don't need to worry about that anymore because I've written it down, to try and clear the mind and stop that racing mind. The other thing that's very useful for that racing mind at nighttime is mindfulness exercises. I find this really useful, and I talk to patients about this quite a lot. Also plays into, as Tim was saying, about the mental health side of things and the management of anxiety and depression. And these are 3 that I recommend to patients. light outside, that's good. As Tim said, you can also get light glasses or light goggles to emit a certain intensity of light into the eye to help wake up in the morning, because it turns the melatonin off. And it's important to get physical exercise during the day, because sometimes people will spend the whole day really busy mentally, and then they can't sleep because they feel mentally tired or fatigued, but they're not physically tired. So the sleeping habits that we want to avoid these days, well, probably one of the most common is the phone or TV in bed. So it's not a good idea, especially the phone shining a bright light in your eyes, but also everything, all that information that you're getting from the phone is not good for the brain and not good for facilitating sleep. We should maintain a good diet, and especially sugar is the worst thing from a sleep point of view. And sugar before bed can cause like a rise in your blood sugar that can be followed by a low blood sugar that can cause waking throughout the night. We shouldn't spend too much time in bed, and sometimes people maladapt by, if they think they've slept poorly, they'll maladapt by going to bed earlier, staying in bed longer. And so sometimes people will end up spending like maybe 10 or 12 hours in bed because they're so worried about sleeping poorly. But if they only need 8 hours sleep, they're always going to spend a few hours awake. So sometimes we actually sleep restrict. And what that means is gradually go to bed a bit later or gradually wake up a bit earlier to restrict the time available for sleep. And that can actually consolidate the sleep to reduce the amount of waking throughout the night. Avoiding daytime naps is a good idea. If people are happy to have a nap and they sleep okay at nighttime, then that's fine. But if people don't sleep well at nighttime, sometimes cutting down the time available for nap during the day or gradually reducing the time available for nap during the day with the view to getting rid of it is a good idea. We don't want to watch the clock because it creates anxiety. So it's a good idea to set an alarm and then just turn the clock away so that you know that the alarm's going to wake you up. You're not going to sleep in, so you can confidently not worry about what time it is. And caffeine and alcohol. Alcohol is good for putting you to sleep, but makes you wake up more throughout the night and adversely affects the quality of sleep. Caffeine lasts longer than what you think. And sometimes we talk to patients and they say, oh, they don't have a coffee after 4 o'clock, but the half-life of caffeine is 6 hours. So if you have a coffee, 6 hours later, half of it is still floating around. And some people are more sensitive to caffeine than others. So it might actually be necessary to cut out caffeine completely or cut out caffeine before maybe 2 o'clock in the afternoon or even midday. So in summary, essentially, the way we approach this is sort of going through that systematically, thinking, does the patient have an underlying sleep disorder? Snoring, daytime sleepiness are the two most common symptoms that would make us think we need to do a sleep study to look for poor quality sleep due to sleep apnea. We want to align the body clock. If the body clock's not aligned, then realigning it is important to improve sleep. We want to optimize mental health. And then it's all about the sleeping habits. So I hope that's helpful. Please feel free to throw questions into the chat, and I'm happy to open it up for any questions that people might have or anything that you'd like to discuss further.